Can you see my screen? I'm not like, I'm learning technology, but can you see my screen? Okay.
And
So,
just so you know, Jonathan asked us to record. So since
okay.
I'm recording now, but if anyone, if we end up wanting to take something off, just let me know and I can edit, later. But I thought it'd be better to wait till we're on the official presentation.
Okay. So, I think that one, like taking a step back, sort of how do new infectious diseases come into human beings? I think that, we have actually confronted new infections in human beings all the time, and it actually is an effect of our interactions with the planet and like our problematic interactions with the planet. So with global warming, pathogens are moving more north, and then they're confronting hosts that they haven't seen before. We're definitely doing a lot more with animals that are, like sort of inconceivable. And that needs to be addressed. And we are changing agricultural practices. We encroach into human animal habitats. We're just more crowded together, and obviously in the setting of jet travel, we're just spreading disease really quickly. And then there's kind of breakdown of public health measures and other major issues that are actually not occurring here. And so, remember that a virus, obviously the corona aspect refers to these little spikes on the surface, and they usually cause the common cold. So it's not like these coronaviruses aren't everywhere. They're everywhere. But there have been 3 times in human history, in recent human history, when the coronavirus has come out as causing a more severe lower respiratory infection. And one was in 2002, one was in 2012, and this is our 3rd time. So the 2002 epidemic, of course, was the SARS epidemic. It started in China, in Wuhan province. It was labeled the severe acute respiratory syndrome, and thus the virus's name is SARS-CoV-1. The current COVID-19 is caused by SARS-CoV-2. It lasted about 9 months in the world. So it was like, went from 2002 to 2003. There were 8,100 cases worldwide. It affected 29 countries, and it caused 29 deaths. So it was different than this one. 774 deaths, but it had a high case fatality rate. And in the US, it wasn't a big effect. We had 29 cases across the US and 0 deaths. There was more happening in Canada, actually in Toronto, for example, from travel to China. And the etiology of probably all of these coronaviruses is the horseshoe bat, and then going through often some sort of intermediary host. In the case of SARS, it was this cat-like mammal called the palm civet. And then it goes into humans. And then once you can spread human to human, that's when you get an epidemic. And then the second one was MERS, COVID, which came out which really was pretty clustered in the Middle East. And it first came out in Saudi Arabia. All cases were linked to the Middle East. So there wasn't a single case that wasn't. It went around the world, but it was much fewer cases, 2,494, 858 deaths. We only had 2 cases here in the US, which were both imported from healthcare workers from Saudi Arabia. And the intermediary host in this case was the camel. So this new coronavirus, was circulating in probably Wuhan province for November and December. It was really on December 31st that the pandemic was, the epidemic, at least at that time, was declared to the WHO. And so it was New Year's Eve when the information came out more worldwide. And really probably the source are these so-called wet markets, of which are these animals really close together, really put in with other animals that they wouldn't have exposure to in any wild situation. And it is that process that will need to be changed going forward, no doubt. The January 7th, it was identified as a new coronavirus. It's been spreading since then. It was January 30th when the WHO called it a global health emergency, and it was March 11th when the WHO called it a pandemic. So this is where we are as of 7 a.m. It's already outdated because it's 8:30, or 8:56. So, things change all the time. Right now, globally, we're at 247,400 cases, 10,667 deaths. That is an overall case fatality rate of 4.1%. Some of that case fatality is higher in places where We didn't know about the epidemic at first and things weren't under control. So take that with an overall rate and then look at what's happening in California and in your city. Mainland China, 81,250 cases. So still account for a large number, though massive slowdown there with public health measures. Italy, you've heard a lot about Italy, and certainly the case fatality rate is way higher than anywhere else and very disturbing at 8.3%. Lots of reasons for that. South Korea is 1.1%. Cases have slowed considerably, and few deaths. And then France, Spain, and Germany. Spain's up to 18,000. So when I mean greater than 10,000, I mean, sometimes more. France is closer to that. United States, as of this morning, 14,250 cases, 205 deaths. That's 1.4% as a case fatality rate. In California, we have 1,039 cases. These are artificial, you have to test to know if there's a case. So these are artificial denominators, but this is where we are. 19 deaths, 1.8%. And in San Francisco, 70 cases, 0 deaths. Our hospitals, I can safely tell you, are prepared. At least I do believe the UCSF hospitals are doing great, really prepared. Teams are activated, and I'm seeing a really smooth response at UCSF and San Francisco General, and certainly not flooded hospitals in the city of San Francisco. It is important to remember that it is a lower respiratory tract infection. So though I do understand that people have fears when they have sneezing and coughing, that isn't really it's not really an upper respiratory infection. Those are more likely to be rhinovirus or other circulating cold viruses. So fever is a very predominant symptom of COVID-19. Not, maybe not universal, but really close to, at least in Wuhan, reported out of Wuhan. So do know that it is a fever cough type of syndrome, which is why fever is so incredibly important in our screening protocols. Like, for example, in lobbies of hospitals or lobbies of clinics, which will start on Monday for Ward 86. Subacute, it can be subacute, it can be acute. So there's nothing specifically distinguishing with that fever and cough. The diarrhea is not that prominent, but diarrhea can be with any respiratory virus. And we give a range of an incubation period, kind of as a longer range of 14 days, which is why quarantine has been defined as 14 days, but really the incubation period generally, the median time is shorter than that. And most people recover. I mean, that is important to say, right? Like, I think when the world says that if I get COVID, I'm going to die, that is absolutely not accurate. So most people will recover. And then there are a subsegment of people who will get more sick. There are some people who get pneumonia, respiratory failure, multi-organ system failure, and death. And our job is to make those fewer and fewer if they're cases. And so I think it's important to talk about the experience in China, but I don't think that until we get our larger population surveys out of the United States, I don't think that you can utterly extrapolate though this is the largest case report that we have right now, of 44,000 cases put out by the CDC in China. I think it's important to say that we need to understand the epidemic in different settings, and including the United States, which that data has not been compiled yet and put together and like really clearly told us what, who of the 205 deaths, who they are, what the characteristics and so forth. So we need a more comprehensive look. I think we haven't heard from the CDC, curiously, for 9 days. And I think that doesn't have to do with the CDC, but our president, but I think we do need a lot more really real-time updates on our data. So in terms of the case fatality rate, it's probably true in any setting that the older ages are more at risk, those who are older, for more severe complications and of death. And so, for example, in this 44,000 cases in China, the younger patients, the case fatality was 0 from 0 to 9 and from 10 to 19. There's been just, it's really rare for children to get, they can get sick but not die. But then, and then even up to 50, people are doing pretty well. Even 50 to 59, it's not very high. So it's really, the jump is after 60 and likely after 65, which is why the governor of the state of California has called 65 kind of a cutoff for people to be really sheltering in place, like really not doing much. And then the older ages, over 80, At least there have been reports of even as high as 15% case mortality. Again, with incredibly good supportive care, everything is going to be, we have to see what's going on here. We need these compiled data in the United States, but this is where we are with the largest case series that we know about. And what came out were these interesting kind of comorbidities. And by I say interesting, I just mean that, like, for example, influenza affects the very young, it affects pregnant women, and affects the old. And so that influenza is a disease that has something to do with immunocompromise. This is not the young or pregnant. And so there's different aspects to this. This is a different virus. It doesn't seem to be specifically about immunocompromise. We don't really have good data on HIV, and we don't seem to see an increase in those living with HIV, but we need better data. But it's these conditions of cardiovascular disease, chronic respiratory disease, diabetes, hypertension, cancer, and the postulation, and there's a lot of great pathophysiology and basic science being already explored, is it has to do with your lung function. It has to do with what's going to go on in the lung and even at the endothelial level and the vascular level, to lead you to the possibility of ARDS, or acute respiratory disease syndrome, which is where people can get very sick and die. It is droplet spread. So I think, boy, this is the hardest thing that you're dealing with, just kind of advising people. Even though, and we need to compile this data again better, and there's lots of really dramatic titles and modeling studies about about asymptomatic transmission. I don't think those are fair at the moment with our current data set. It seems to be spread through respiratory droplets, and so are many viruses. So it's not strictly airborne like tuberculosis, which is why negative pressure rooms are being abandoned. Like, I talked to my brother last night, he was at Mass General, and no one's in a negative pressure room at a very high level hospital in Boston, who's being ruled out for COVID. They are all in low level respiratory isolation. So I think it's important to say that it is a droplet spread infection. We know how it's spread. That's coughing and sneezing. 6 feet is plenty for people to not have a droplet land on them. And that's why the 6 feet number is being used. I think that transmission from people who are pre-symptomatic is possible. I think that contribution of that is smaller than people who are symptomatic. And I think that all these precautions are absolutely 100% working and going to work. I don't think it's going to be, even if it's cultured from stool, I don't think it's going to be spread from stool. And perinatal, we haven't seen perinatal transmission. Why is it spreading so fast? It doesn't actually stay longer on surfaces than like SARS-CoV-1. It doesn't stay longer in aerosols than SARS-CoV-1. So it's not this mysterious like contagion, I don't know, movie star virus that has, that's different than a droplet spread virus. It is possible, however, that prior to symptoms, just prior to symptoms, that shedding could occur. I mean, that is probably true, that shedding is occurring in the respiratory secretions right before someone gets symptoms, probably right before is higher than like days before, for example. Still, I think it's a low rate of transmission from that pre-symptomatic period, but I think it could be occurring. And in terms of the contagiousness of this virus, so, it is, it's like in the middle, right? Like, what I mean by that is, if this was measles and measles had become droplet spread, or like smallpox, which is gone, had become droplet spread, that would be very problematic. So it's in the middle, and Ebola and influenza are less infectious or reproductive, this kind of, the R naught, or the basic reproduction number. And then MERS is lower still, which is why we really, when I compared SARS and MERS was really quite a low infectious rate. So we're kind of in the middle with this. So what that means is that from one infected person, the average number of infected people are 2 to 2.5. This is more for the clinicians, so I'm not going to go over it. In terms of labs, I would say that like relatively maybe leukopenia instead of higher white counts, and imaging is somewhat interesting. It is often abnormal. Chest x-rays are abnormal in 77% of people with severe disease, and in even 60% if you don't have severe disease. So we are doing quite a bit of chest x-ray, just plain film screening. And chest CTs are also abnormal, but China had a system by which CTs are done very frequently. We are limited by CTs, and we're not doing those in everybody. And I don't think that's important to go over the imaging findings for this audience. Okay, so this is not true. The tests are not all perfect, and as of yesterday, it's not anybody who needs a test that can get one. So that is not where we are with testing, and that is certainly the biggest criticism that's going on. The biggest concern that's going on is where we are with testing. Countrywide is expanding. Laboratories are developing their own capabilities instead of relying on the CDC labs, test labs that are being sent to the San Francisco DPH. I asked my brother yesterday, again at Mass General, they developed their home test or their, it's very reminiscent, by the way, of what happened at the beginning of the HIV epidemic. Like you don't want to rely on the government to do the ELISA testing for HIV. You want to like quickly get up an ELISA in your lab. And that's what is happening around hospitals everywhere. MGH now has Mass General has the capability, I think, of 200 lab tests a day. We are kind of doing an inequity thing right now in the city of San Francisco, and I know everyone's working on it. There's a great task force working on this, but right now the San Francisco General labs are being mainly sent to the SFDPH with the CDC labs. They are also doing a great job. The SFDPH are sending out our labs, are doing our lab testing, and it takes about 24 to 48. The problem at San Francisco General with our population is outpatients will get sent to commercial labs like Quest and something in Salt Lake called Arup, and it's taking up to 5 to 7 days, which is unacceptable for a lab test. UCSF lab testing is absolutely increasing because they have an in-home test at Parnassus, like kind of in-lab test, and then there's a fancy machine, which some of you will know about because you're in this field, that has been sent over to China Basin, and that capability is maybe 200 samples a day, certainly more than 100, and is going to get up higher. We need, of course, to be able to access that laboratory testing capability for our patients at San Francisco General to not create up inequity in the city where people with insurance get better testing than people who don't. That would be replicating what's happening with HIV, and that would be wrong. In terms of how to order this test, so again, we don't have a serologic test at the moment. This is absolutely being developed. At the moment, it is a swabbing of the nose and the mouth, the back of the mouth, and then sending that in for this real-time PCR tests. That's why people run out of reagents. That's why it's like not easy. That's why the turnaround time is not an hour. And I think many of you are in the lab, so that can be explained to your friends and family that it isn't like a finger prick that you can just do in a second. And there's real limitations of what it takes to do an RT-PCR test. Looks like both nasopharyngeal and oropharyngeal together is better than doing a nasopharyngeal swab. But if you're going to choose which one to do the nose. Okay, I'm not going to go through this for this audience because I just think it's not the scope of this what we're talking about here. But there are absolutely treatment options. They're mostly in study. Lopinavir and ritonavir, 2 days ago in the New England Journal, the study looked like it wasn't efficacious. There were problems with that study. It wasn't given until quite late, median of 12 days after the onset of disease. Really, you need to shut down viral shedding really fast. So that will be interesting to know if PIs have efficacy. But with that large trial published, I would say probably it's not going to happen. And that question is pretty much dead. Hydroxychloroquine is being mentioned by the president and others. Again, more studies needed, but hydroxychloroquine is being pretty much pulled out from around the country and being given quite freely without evidence to people, including at our own hospital. We actually bought 7,000 tablets the other day, and we have enough for 550 patients in our hospital. Hydroxychloroquine, its name is Plaquenil, so that is usually used for rheumatoid arthritis. And then remdesivir is a antiviral that actually does have in vitro, RNA virus activity, and there's a large NIH trial going on, multiple centers, and UCSF San Francisco General is one of them. You've heard this many times, the reason that again, not mysterious, this is how you prevent a droplet spread infection. You wash your hands. You actually wash them for longer than we usually wash them, 20 seconds. There's music apps that are singing the birthday song twice, that are singing through the alphabet. You avoid close contact with people who are sneezing and coughing. You don't hug right now. You avoid touching your eyes and mouth. You stay home when you're sick. You cover your cough and sneeze with a tissue and throw the tissue away, or your elbow if you don't have it. Um, and you can clean down surfaces. But the important aspect of this and why we're in the situation that we are, Brenda, is because people don't do these readily. It's we couldn't actually change behavior. It's very hard to change human behavior. And so just because you tell everyone to wash their hands and you tell everyone to stay away from each other, that isn't going to actually happen as readily unless there are government mandates to do so. And that's what happened in this city faster than any other city in the US, that a government mandate happened. And so what do we mean by government mandate? Well, there's no doubt that staying away from each other is a good idea right now. And so what does this mean? So it does not mean that, like, if you're well and your friend is well, that you can't see your friend. It is really important to know that it's not mysteriously, again, spread by, like, some sort of alien movie. Like, that's not what's happening. So we do know that people who are well can be in the same room. It's more that we did all this public health measures were to control human behavior, because we really do need to. We're kind of out of the phase where we're doing contact tracing from everyone who has COVID in the city. I mean, meaning that can happen, but as we expand and more cases are occurring, it gets out of that phase and it gets into the phase of just kind of keeping everyone away from each other. And you keep on hearing this phrase, flattening the curve. And what you really mean by that is you don't want all the cases to spike at once. People are going to get COVID. People are going to get COVID and they're going to be fine. There are prominent HIV researchers at the University of Alabama, Birmingham, who it's declared in the news that he had COVID and he's absolutely fine. Like, people are going to get COVID. But the question is of not having people get it all at once, people who are older get it all at once, and then have to come into the hospitals at the same time. Because there's no doubt that if hospital personnel and if rooms are flooded, that people won't get good care and they will have poor outcomes. So the idea is to just have it simmer and have people stay away from each other so that you get transmission at a lower rate, so the people who do get sick go into the hospital at a lower rate. And at a certain point, we'll get into mitigation where we'll have better antivirals. This is why remdesivir is in such active study. We'll have a vaccine in a year, maybe someday. You guys maybe will contribute to that. And we will protect the older patients, and we won't all be sitting and sheltering in place. I mean, there's no doubt that this is not going to go on forever. But it was the right thing to do. It was the right thing to do because you can't control human behavior. And so this is that so-called flattening the curve, that you just don't want it all to happen at once. We learned this from influenza in 1918, from a case of two cities, Philadelphia. Social containment didn't happen, so all the cases occurred at once. Hospitals flooded. St. Louis, you did it, kept people away from each other, and transmission occurred at a slower rate among populations, and that's what you want. That's what you want with a disease that can cause mortality. So this is where we are. That's why this is happening. It's not because it's spread. It's really not because it's spread just by looking at someone. We know how it's spread, and I really just want to stress that it is unprecedented to do this. None of us were alive in 1918 to remember the epidemic of Spanish flu, but it is unprecedented, but it's necessary. And now I'll stop and let's do questions and discussion.
Monica, this is Lauren. They're actually, CDC did put out an MMWR yesterday.
Oh, good. Sorry, I didn't see it.
If you want to look at it, or
we'll
we can
put
just
that in here. Yeah, perfect. Did they share the characteristics of cases?
Yeah, let me pull it up.
If you can share it, yeah.
I have a question. Thanks, that was really interesting and informative. My question is, with these previous epidemics, not necessarily swine flu and so on, there was no response like this. Is this virus actually different? I mean, in terms of infectiousness or risk, or is it really just that a new, at a policy level, the approach has changed?
I mean, yes, it is. So how is it different? There's a really nice MMWR on I'm sorry, WHO analysis on comparing influenza to COVID-19, which I think is a good comparison. So it is more infectious and it has a higher mortality rate than influenza A and B. And on the other hand, it is not spread mysteriously. So 2 billion people have tuberculosis worldwide, right? Like, so airborne transmission leads to 2 billion people having something. So it still seems to be droplet spread as opposed to airborne. That's a little semantics in a way because it can exist in the air for a while. But it isn't different. It's just that it isn't different than respiratory viruses. It's just that it's spreading quickly. It's likely that people right before symptoms there's no doubt they have viral shedding, so they could spread it before they have symptoms, which is why the purpose of social distancing. I mean, you're not around anyone with symptoms or without symptoms, unfortunately, right now. Like, no one's around each other. So it isn't it not being recognized before people were traveling from China everywhere, not the containment not happening in China quickly. That contributed. There's no doubt that contributed. You want to contain quickly and decisively and shut down quickly, and that's what happened in San Francisco. That's what happened in a province in Italy that's doing great. That's what happened in South Korea. So there are many examples, and that's what's happening in China for sure. Relatively soon into January, but it just wasn't happening in November and December. So that allows for spread. The recognition of the epidemic is required for social containment, and somehow the recognition or the containment was not happening earlier on.
Yeah, I suppose I'm just thinking about things like global warming and something. I mean, there's
Yeah.
an argument that we can't do much about global warming by the kind of opponents because of the economic impact. And now we've got like the entire world economy virtually shut down, apart from a few essential parts of it. When you've got this other threat that's an existential threat too. And
I think that's very, very important and interesting. I'm sure you've all heard how well global pollution is doing right now. Like, we're actually, like we're improving global warming by all this. But yeah, I think that's very important, and I think there's no doubt that global warming it played a role in Ebola. Pathogens are going to want to be cooler, and they will be exposed to hosts that they haven't seen. There's no doubt.
Hey, Monica, this is John. I had a question kind of in your role as medical director with operations and supplies. Can you explain sort of why we're seeing the shortages that we are? Is it that people are running through much more product for preventive purposes, or is it that maybe hospitals didn't do a full kind of really intricate assessment of like what would be needed in a pandemic?
Yeah, I mean, I think that two things. There was a lot of personal protective equipment and masks that walked away in the hospital. So like really early on, I don't mean by early, I mean like February, they disappeared. Like, people just took them home, and that led to a shortage. So there's no doubt that happened. That's happening with hydroxychloroquine, by the way. So we restricted hydroxychloroquine in our hospital. I think hopefully most places are restricted, but people will get a hold of things that they think could help, and they will hoard them. And healthcare workers are not immune to fear as well. So that was happening. And then people are using masks when they're not indicated, and kind of droplet spread infection. Actually, you again, if you're not like up close with the patient, intubating them or doing a swab or something, you actually need a surgical mask with the ear loops, so you don't need the N95 masks. So it's people misusing, and it's fear. I mean, it's fear. That's what led to a lot of the disappearance. There's no question. I can't like say it in any other way. And then now they're ramping up production.
I have one more question, if that's okay. That's all right. Just What? How certain are we that this is a new virus and that it hasn't been circulating previously?
I'm sorry, I didn't say that again.
How certain are we that this is a new virus? How good is the evidence and that it hasn't been circulating previously?
That's a great question. I don't know if anyone else on the call would know that. Like, I do know that when it was identified on January 7th, it was identified as, they called it a novel beta coronavirus. So it hadn't been described the WHO prior to that by its sequencing. So that's where I got the idea, that's where I think we get the idea that it's novel. There are coronaviruses like this sitting in bats. I mean, that bats are the original source. They don't get sick, of course. And then it has to go through, I think it's certainly not determined yet where it had to go through to get to humans, which intermediary host. But that's a great question. I don't know if anyone else has any insights on that.
There's a good presentation from Croy on the coronavirus update with the basic scientist who is the coronavirus expert
From UNC,
at UNC, and I guess Barrick, I think is his last name, and he sort of shows where it is in the phylogenetic map, where it's about, I think, 27% different from the SARS-1 virus. There's a pretty good Netflix show called, I think it's called Pandemic or Epidemic or something like that. And, they, in one of the episodes, they talk about general viral surveillance, where people will catch bats and sort of test them and see what sort of viruses are circulating as a part of global health security, particularly in China and in Egypt and Lebanon, and where there's a lot of potential bat to livestock or bat to human transmission. So there is surveillance happening on that.
Hi, Monica.
So this is the CDC report that Lauren mentioned. So I guess what I meant is that they're not able to make that many public statements, I think, apparently. But 1 second.
It looks pretty similar to
here. It's a little different in the sense that older patients, I actually think this is very interesting. I didn't see, I have to put this in my talk, but like, you can see that, up to, like, I think this is really interesting that less than 1%, less than 54 years, that was a little, I think that's similar. And yeah, so the 85, this is a big range. We will send this out and the slides, and there are many boxes that are being shared for people. I think this age thing, we had a really interesting pathophysiology talk yesterday, and I think it'll be hopefully posted. But if you go to Medicine Grand Rounds at UCSF from 12 to 1:30, there was a talk in that series by Michael Mathey, who is an ARDS expert he's a pulmonologist, trying to explain why age would, be such a risk factor for severe disease and ARDS. And that has to do with just like endothelial function in the setting of just non-compliance. You don't have great endothelial function with hypertension with older age. So maybe that will help you explain this age phenomenon.
And the other thing that I thought was interesting, the New York Times covered the CDC MMWR yesterday, actually in a way that I think was not very, it wasn't very good.
Okay.
They had a denominator issue where they basically took the position that young people are at risk, whereas I think that probably in the early days of this, there were probably more young people hospitalized just for containment purposes.
Yes,
but if you look at the disease,
so true. Yes,
the
that
disease status,
yeah.
So they were saying young people made up, 20% of hospitalizations or something, but if you really look at who has bad outcomes, it matches the data coming out of Hubei province.
I have a question about data sources.
obviously, as we've said, there's a lot of misinformation out there, and I generally think, of CDC and the Departments of Public Health as good sources, and also I know a lot of people are using that Johns Hopkins map that you showed at the beginning, Monica. But I noticed this morning, for example, that the Johns Hopkins map says that there's 1,000+ cases in California, and the California Department of Health is reporting 675 cases. And that's a pretty big difference. And I wondered if you, if you have any idea why that might be, or.
So that is the rapid changing thing. So I just looked an hour ago, and it is California has 1,039 cases, and that's the DPH. That's the California DPH. So it is this incredibly, like, if you look an hour and a half ago, you're gonna go get a different number. Than that's why, like, whenever I give a talk, I'm literally looking minutes before. So it's just dynamic. It's incredibly changing and dynamic. So right now it looks like 1,039 in California.
Okay, thanks.
And then it's ascertainment bias and all of that, right? Like we have really truly no idea of the number of cases without universal testing. That's by definition. So these cases are just rising when labs are developing more capability. That's it.
And there's some links in the chat box. So Matt Hickey linked the CROI session. So if people want to watch that, I just put in the MMWR. And Sushama wrote an answer about the sequence similarities. So just take a look
great.
over there.
Chat, where's that? I see. Okay. And I do also want to and we can go back. So the CROI session, and that's so great you linked to it. I would go just to that talk from the UNC guy, only because some of the stuff is outdated. Obviously from the CDC talk, which was fantastic, but that talk is fantastic from UNC. And then it looks like Sushama specifically says, yeah, that SARS, the COVID-2 does disappear. It does for SARS viruses. And then the link to the MMWR. Okay, so I did want to just do one other thing, and then we can go back to questions, which was, and we're going to put out guidance to the CFAR community on Monday in an email, but you already know this because you're already working with NIH grants, but it's not like the NIH hasn't massively responded to understanding what's happening. So there's a lot of leeway in terms of grants. Let me try to actually just show some things. So a lot of leeway, a lot of new grant opportunities, all of that, right? So late applications. Can you see this? I never can tell if people can see stuff. Can you see a slide?
We can see it. Yeah, we're good.
Thank you. Our division manager has been really clear. You don't actually have to ask permission and that's this prior approval is not needed for a late application. But when you submit an application late, then you just have to justify it. I don't see how you have to justify it in any other way by just saying like COVID. So obviously research has been closed here in wet labs since Sunday night, and clinical research is really only to be restricted to where there's a benefit to the patient. So our research enterprise at UCSF has closed down in terms of active experiments, and we can keep our labs, certainly like the nitrogen and freezers and so forth filled, but we are not to be, the laboratory staff are not to be in the laboratory and doing active experiments. And so it's really, I think, very easy to justify applications not being turned in time for the NIH deadline in May. Late progress reports as well. And we will send out, when we send out the recommendations on Monday and what the NIH is saying, a really nice video that they made, which I thought was very reassuring, and like totally get it. And they're also like hunkering down, and they're crazy, and everyone is, and so they totally understand all of this. So late progress reports can be late. Delays in research progress, there's no doubt if you shut down your research lab that there will be delays in research progress and unanticipated costs from that. And so that something that was supposed to only go for 12 months, they will allow additional extensions beyond that. And I think we have to figure out with the NIH, and that will be part of our job at CFAR, is about T32 extensions. People being, especially for you early careers, being longer on a T32 than the usual 3 years, given what's happened. And I'm positive that will be just naturally. I don't know if you have any insight on that yet, Lauren, but it has to happen.
I'm sorry, what was
like T32 extension? So being longer on a T32 than 3 years, when like 3 or 4 months will have been taken out of life.
Yeah,
So,
I mean, I haven't seen anything specific on that, but they definitely seem to be, that sort of unanticipated cost. They're sort of waiting to see how things are shaking out, and then they'll come up with a process for covering those unanticipated costs.
yeah, I think there's no doubt that you should not be worrying. That the NIH is there. They're also, shut in, and I don't think you should worry. I think there's going to be a lot of leeway, lots of flexibilities. In anyone who has any activities affected by COVID-19, that by definition would be every single person in the universe. So, I really, this will be okay. If you look ahead and worry about that, please don't worry about that. And these flexibilities will be extensions to reporting, and probably extensions on T32s, and prior approval requirement waivers, and the salaries that they need to support their research staff, and all of that. And then there's of course supplements to actual grants. And so now it's NIDA, NAID, NIGMS, and NLHBI. And put out these what are called NOSI, notices of special interest. And we'll have links and all in our update on Monday, but definitely talk to your program officer if you have a specific COVID related question on your K, if you're on a K, and how you would, leverage and try to get a supplement to study the question, whatever you're studying, and how it would have relevance to COVID, to put in that supplement. And a lot of people are doing that. And I think there's going to be more and more money for coronavirus. I mean, let alone just on current grants. Certainly there's going to be PAR after PAR on new novel projects with coronavirus. So this is, for those of us in HIV research, this is repivoting your research, especially if you're a basic virologist, towards this important virus at the moment is a very wise thing to do. If you're an inflammation researcher, thinking about the inflammatory consequences of COVID and how they relate and how you could extrapolate from what you've learned from HIV is a great thing to do. There's something about this that's bizarre, that the inflammation can lead to, overwhelming responses in some. It's the inflammation is not activated in younger people who actually have very active immune activation responses. So like there's many basic questions to study, no doubt. And then I think for those of us in clinical research, or those of us in social behavioral research, there's just going to be so much to do. I think with the people living with HIV, implications for them, social isolation, implications for virologic expression rates. I think there's going to be so much that we need to study. So let's just now open this up. I think I can only go to 10. I'm sorry, there's a lot happening, and I'll let you in the clinical level, but let's open this up for the next 25 minutes, and then we can stop recording, Lauren, so that people can all